you so much, Deborah, and thank you so much to everyone here. Good morning. Thank you so much for having me. It is an honor. No pressure. I'm expecting some really good questions, which I'll do my absolute best to address. So what we're going to talk about this morning, if you don't mind me jumping straight in, I'm going to organize my presentation this morning in 3 separate sections, the bulk of which focusing on effective strategies to connect individuals involved in the criminal justice system with coverage and services, and using different examples from different states to get a sense of what different states are doing currently that might be models or examples for us to look at in our own states. So I'm going to start with a brief overview of the scope of the problem, just really emphasizing the significant health needs that people involved in the criminal justice system have, and what we can do in an effort to improve public safety and health outcomes when more and more people are returning to the community. And second, as I mentioned, I'm going to introduce strategies based on available research that we have, and best practices with what states are doing and what might be able to be replicated to realize the benefits of improved access for individuals involved with the criminal justice system to health coverage and services. And as I mentioned, I'm going to be using case examples to demonstrate what different states are doing. Third, I'm going to introduce some key implications, implementation implications for states that, once you're connecting more and more individuals with health coverage and services, there are certain issues that systems are going to have to face to, respond to this larger number of people who are going to be connected and have access to coverage. So we're going to talk a little bit about what these different system implementation considerations are and what we know and what we don't yet know. And last, I'd like to spend some time for questions, and I'm going to show you a couple resources. So, as I mentioned, this is a significant public health problem. People in prisons and jails often have complex and costly health care needs. This population has high rates, as you can see here, of chronic and communicable diseases as compared to the general population. In fact, a Bureau of Justice Statistics report estimated that prisoners have a 20% greater risk of death compared to the general population. And you can see a little bit here why. And also, a significant proportion, as I'm going to show you actually in subsequent slides, also have substance use disorders and mental disorders. So even further complicating their needs and calling for really comprehensive physical and mental health care to address these needs. So this public health problem is compounded by the fact that a significant proportion have substance use disorders, as you'll see here in this study, compared to the household prevalence rate of drug use disorder and alcohol use disorder. This is based on the old DSM classifications. We're separating out drug and alcohol. You'll see just incredibly high rates for jail and state prisons in both of those areas. And mental health as well, serious mental illness. There's high rates of serious mental illness in our jails, in our prisons, and in our criminal justice system broadly. Exact prevalence is complex to measure exactly for a number of different reasons, but our best estimates show that while 5% of the general population has serious mental illness, 17% of people in jail have serious mental disorders, and of those individuals, 72% also have a co-occurring substance use disorder. So something you'll hear all the time in the criminal justice system, or more so now than ever, and also in the behavioral health field, is that co-occurring substance use and mental disorders are the norm and not the exception. So we need to be thinking not just about mental health services, but also connecting individuals with substance use services as well. So states and local governments currently pay almost the entirety of individuals' health care costs. So as you can see here, The California corrections spending was estimated to be about $2.1 billion, or 22.8% of their annual adult inmate health care for the fiscal year of 2010-2011. And similarly, high numbers in Ohio, 15% of their corrections spending was for health care. So estimates suggest that some $7 to $10 billion is spent on correctional health care annually. This is something that I'm sure you're all very familiar with. This is not a surprise to you. But let's talk a little bit about today some strategies that might be able to alleviate some of these costs. Lack of health insurance coverage is strongly associated with a higher risk of illness and death. And this holds true for those involved in the criminal justice system. So historically, somewhere between 68 to 90% of people who are involved with the criminal justice system have been uninsured. And so this has really significant implications for reentries. I'm going to talk a little bit about, but putting them at further risk of death and of just poor outcomes. But the good news is coverage can improve health outcomes. There's evidence to suggest that expanding health coverage to vulnerable populations can help combat these high rates of morbidity and mortality. So a 2014 study looking at mortality data among individuals in Massachusetts, that first bullet there, before and after healthcare reform in that state, demonstrated a significant reduction in the risk of death in the wake of expanded health insurance coverage rates. And another study in the Journal of the American Medical Association 2012 looked at among states that had expanded their Medicaid program's eligibility criteria early. So they looked at Arizona, Maine, and New York. An analysis by the Harvard School of Public Health found that there were improvements in health and fewer deaths than would have been otherwise expected. And a pretty significant finding is they found or reported a 30% reduction in risk of death for an individual who's gaining health coverage. But what do we know about the impact of accessing care on public safety? Well, the research on this issue is not as robust as the connection between health outcomes and health coverage, but we do have indications that connecting individuals with healthcare and services does have an impact on recidivism. So I'm going to show you a couple studies here. So an analysis of the effect of health coverage on public safety in King County, Washington, this first bullet there, found that individuals with serious mental illnesses who were enrolled in Medicaid at reentry experienced 16% fewer detentions during the following year than those released without coverage. So that's pretty significant implications. The study also found resulting cost savings to the criminal justice system of $1.06 for every dollar spent, with additional savings accruing as a result of reduced costs to crime victims and lower overall medical spending. Also, a study conducted by Dr. Faye Taxman found that connecting individuals with evidence-based substance use treatment while incarcerated and also upon reentry can lower rates of subsequent substance use and recidivism. So these are very important implications for criminal justice systems that are really struggling with the burden of elevated recidivism rates. At the same time, more and more people are returning to the community from jails and prisons. And as this graphic illustrates, as I will show you here with my fancy clicker, a significant proportion are going to be under probation, supervision by probation in the community. And this is consistently rising, as we're seeing here. So this has important implications also for how individuals are connected with care in the community while under supervision in the criminal justice system. And I apologize for the very small font here. Hopefully you might be able to pick out your state. I'd be happy to share a version with this, or a version of this study with you so you can see exactly what your rate is for your state. But the main takeaway from this slide is as the number of individuals under supervision in the community climbs, the number in prison seems to be declining in certain states, and more people are returning to the community in those states. At the same time, the jail population seems to be declining. This is actually a very brand or quite new study that came out conducted by the Bureau of Justice Statistics. And it shows that a decline in 2013 of the number of inmates in local jails, as you'll notice here. But interesting to note that the female population is growing, which certainly has implications on what communities are offering in the way of gender-specific and gender-responsive interventions. So it's just important to note that. So reentry is a very vulnerable time for individuals returning to the community. I'm going to be focusing a lot on that period or that intercept in the criminal justice continuum. High numbers of people are released from jails and prisons, as I've just mentioned. Approximately 650,000 individuals are released from prisons each year. It's a huge number. And over 7 million different individuals are released from jails. So as we discussed, many individuals returning to the community from jails and prisons will be uninsured. So this can lead to disruptions in continuity of medical care that's been shown to increase rates of reincarceration and lead to poor and more costly health outcomes. And most people released from jail and prison recidivate. We have some studies that show us that 30% of individuals released from state prisons will be rearrested in the first 6 months following their release. And within 3 years, the percentage increases to 2/3 rearrested. And over half, 52%, will return to prison for either new crimes or parole revocation. It's also a time that's marked by very elevated health risks. For many, failure to provide a link to healthcare coverage and services results in needless, potentially month-long gaps in accessing care. There is a study here that found that there's a higher risk of drug use following release, and this statistic is particularly disturbing. A 12-fold increased risk of death in the first 2 weeks after release. And many of the individuals found for this in this study, this was associated with higher risk of drug use, which is worth noting. So if individuals access care at all upon reentry, they often rely on hospital emergency room services. These are individuals who are uninsured, which results in shifting much of the cost burden to hospitals and state and county and city agencies. Bless you. I'm only going to talk today just about the implications of the ACA and under certain opportunities, but it is something to note that there is the majority of criminal justice involved population would be newly eligible for health coverage, either through Medicaid or through publicly subsidized health insurance coverage, and through the otherwise known as the marketplace. And so there's wide agreement that the majority of people who are involved in the criminal justice system would be eligible for coverage with states that are expanding Medicaid. But for states that aren't, there are an increased number of people who would be eligible for services under the publicly subsidized health insurance coverage. So now I'm going to shift directly to what opportunities are presented for criminal justice systems to connect people to coverage and services. I apologize, again, for the small font of this chart, but I thought it would be useful to kind of give you an outline of how I'm going to be talking about these different opportunities. So based on available research and best practices, here on the left-hand side, these are interventions that have been identified as being essential to realize the benefits of improved access to health coverage and services. And in order to better understand what the efforts that different states are undertaking to improve access, the Langeloth Foundation, based in New York, funded the Justice Center to convene a day-long meeting in December 2013 with health and corrections officials from 8 different states. California was in attendance, Connecticut, Massachusetts, New York, North Carolina, Ohio, Rhode Island, and West Virginia. So I'm going to be using a lot of what we learned from those states as examples during my presentation today, and I'm actually currently working with a colleague of mine who is our sort of director of health policy. She recently had a baby. We're working on putting together the proceedings from that meeting, and we're going to have a document that will come out that will provide more detail on these different strategies. But you're going to get a sneak preview today to give you a sense of what different states are doing. So I'm going to talk through, under each of these key intervention areas, these different strategies or approaches, and then use case examples for each of those. So let's look first at what states are doing to enroll people involved in the criminal justice system and health coverage. So first, important to note why enrollment is important. Increased enrollment leads to enhanced opportunities for appropriate diversion of individuals to mental health or substance use treatment, reduced corrections spending on qualifying inpatient medical care of more than 24 hours for Medicaid eligible inmates. Now this is a Medicaid exclusion that I'm going to talk to you more in a lot more detail, because this is a very interesting exclusion that a lot of states are taking advantage of. Improved access to and continuity of care upon release, and as we just talked about, that's very, very important in terms of protecting the investments that are made in healthcare behind the walls, and also the appropriate use of health services out in the community, so individuals aren't relying on health, emergency care of really, really costly hospitalizations. Decreased burden on local and state-funded health services, and better health outcomes and reductions in recidivism, which are things that we also care about. So, in order to identify those who are eligible and assist them in enrolling, put very simply, this requires putting in place eligibility determination processes at each point in the continuum of the criminal justice system. So ideally, you would have mechanisms to identify and enroll people from booking to reentry to individuals on parolees who are under community supervision. I'm going to be focusing a lot on efforts that states are making behind the walls in jails and prisons, especially prisons, because of the amount of time that someone is likely to be in a prison versus a jail setting. But we're going to be talking about both settings and what different states have done to prepare for reentry. But just to set the stage for the ideal system would also be able to enroll people at all multiple points in the criminal justice system. So these are strategies that different states are already using or that they've identified and are implementing. So making eligibility determinations for health coverage a standard component of intake and reentry processes. So incorporating it into discharge planning. Forging a strong working relationship with the state Medicaid agency and the marketplace, and identifying strategies to sustain staff time that's needed to assist with enrollments. Many states have in their Department of Corrections, or also, as I'll show you in a moment, housed in Health and Human Services, but working with specifically individuals who are involved in the criminal justice system. They have dedicated staff for processing applications, because it can be time-consuming to identify eligible people and process applications pre-release. So, let's look at a couple different examples of what states are doing in this area. Massachusetts, in Massachusetts, the Department of Corrections, actually, do we have anyone from Massachusetts in the room? No, okay, just want to check. They incorporated enrollment into reentry planning in the Department of Corrections in all of their facilities. So they have dedicated enrollment specialists, and by 2013, 94% of state prisoners returning to the community had active Medicaid on release. That is unprecedented. It's very, very impressive. So by dedicating resources to having these dedicated enrollment specialists, they were able to maximize the number of individuals who are returning to the community from jail and prison and are able to access services through Medicaid the day of their release. And this also built into a more comprehensive discharge planning process that I'm going to talk a little bit about more later, that of course it's not just connecting someone to services and then, okay, there you go. you'll be able to access those services no problem in the community. It's also incorporating more of a comprehensive discharge planning process to make sure that people are connected with providers upon leaving, that, as we talked about before, the first few hours even after release are so critical. So building this into a more comprehensive discharge plan, but it's very, very, very notable and impressive that they're able to access Medicaid immediately upon return. California is also expanding their existing efforts to identify and enroll those eligible for Medicaid. They're increasing the number of full-time staff that are working in the state's 34 prisons to complete pre-release applications ahead of release. And pre-release applications, this is a little bit different actually from Massachusetts, where they will complete Medicaid applications directly. In California, they're doing something interesting where their pre-release applications they use the state marketplace paper application and process that application through the marketplace to not only determine if eligibility for Medicaid, but also for publicly subsidized private coverage, which is also very important for states that have elected not to expand their Medicaid. This is an interesting option, using the applications through the marketplace in order to facilitate enrollment. So this demonstrates 3 strategies in action, as I mentioned. So incorporating healthcare determinations and enrollment into standard operating procedures, dedicated enrollment staff specialists, at reentry, as they do in Massachusetts, and actually Connecticut has a different approach where they have a very more comprehensive enrollment strategy where they actually enroll at multiple points in the criminal justice system, as I mentioned, where they do enroll people at booking, they do enroll people behind the walls and in the community. And I can talk a little bit more later if you're interested in how they're able to achieve that. And also completing pre-release applications using the state marketplace application to assess eligibility for Medicaid and publicly subsidized private coverage, as California is doing. So back to our chart, we're going to turn our attention now to keeping individuals enrolled in benefits. So once they're enrolled, how do you ensure that they don't lose that coverage? Because there are some interesting practices that have gone on or that are going on to terminate Medicaid upon incarceration. So we're going to talk a little bit about that to understand why that might be happening and different strategies that states are taking to make sure that Medicaid is still active but suspended. So state correction and health human service agencies are dedicating significant resources to enrolling eligible individuals in health insurance coverage. But many states are undercutting these efforts by unnecessarily terminating Medicaid for those who are detained in jail and prison. We're going to talk a little bit about why that's happening. 2 main factors have perpetuated this practice of termination of Medicaid. First, there are federal regulations that prohibit the use of federal Medicaid matching dollars to pay for services provided to an inmate of a public institution. And many states have incorrectly interpreted that this requires termination of enrollment from of Medicaid enrollment upon incarceration, when in fact it doesn't mean that. It just means that states aren't able to bill for services provided to individuals who are incarcerated, except for one vital exclusion that we're going to talk about for inpatient inmate care. Also, another mechanism that has been exacerbating the practice of termination is that the Social Security Administration actually offers incentive because Medicaid eligibility among the criminal justice population has most often been tied to disability status. So a huge number of individuals also are receiving SSI or SSDI, particularly those who have serious mental illnesses. So the Social Security Administration has a practice of offering monetary incentive to prison and jails to report lists of incarcerated individuals, and that has resulted in the termination of both SSIDI and, in turn, Medicaid. And as I mentioned, just reiterate again, there is no requirement that Medicaid enrollment be terminated for inmates, only that payment for services be suspended until release. So federal rules prohibit the use of federal dollars to pay for inmate health services with, as I mentioned, one financially significant exception. So why suspend versus terminate? Well, suspension of benefits leads to increased access to care upon reentry. So people are able to be linked to services, appropriate services, upon reentering the community, which of course enhances continuity of care. Terminating benefits is counterproductive and actually undercuts the investment made in healthcare services in jail and prison, which, as I showed you before, is astronomical, the amount of money that corrections budgets have to devote to providing or paying for healthcare services. It also results in significant financial savings through this very important exclusion that we're going to talk about. I keep building up suspense to it. I apologize. CMS encourages states to suspend. So that's a very important reason, I think. I'm going to actually point you to a handout that you have in your really, really impressive binders there. It's on Medicaid and the role of Medicaid in enhancing or financing care for individuals who are involved in the criminal justice system. Let me just show you what it looks like. Here it is. So that's in your binders there. And actually, I will refer you to this as a very specific resource to give you a lot more detailed guidance on the role specifically of Medicaid in enhancing coverage for people involved in the criminal justice system. But I'm mentioning it now specifically because there are, as a series of appendices, here we are. There are letters from CMS, and there is the documentation from CMS that really clearly states and provides guidance for states on their expectations with regard to Medicaid and really enabling states to implement these suspension practices rather than termination. So I just wanted to point your attention to that in case you're looking for some light reading on your way home. Oh, I should also, I'm sorry, I didn't mention this very colorful map at the bottom. So this is a map of states that have laws or administrative processes to suspend Medicaid for individuals who are incarcerated. And I'm going to be highlighting a couple of them, but it's very useful to see this list because, or actually I could help you if you're interested in finding those specific examples of laws and policies specifically for language that other states have used. And I'm going to talk about, I think I'm talking about New York and Ohio specifically today, but there are other examples here, as you can see, of other states that have implemented these different laws and policies. So here's a case, Medicaid suspension in action, an example from Ohio. Ohio passed a law during the 2007-2008 session of the legislature, which required the Department of Job and Family Services, which is where the Medicaid program is housed in Ohio. Do we have anyone from Ohio in the room? No? Okay. Just like to check. To take steps to implement this policy. So Ohio Medicaid program worked with multiple departments to put policies in place to identify individuals enrolled in Medicaid upon reentry or entry to their system. So as soon as someone hit their systems, they had a coordinated response where that would trigger that person's benefits were suspended rather than terminated, which ensures a reactivation of benefits upon release. So it's very important to actually highlight here that this is not something that Department of Corrections did alone. This is something, as you will also hear through the example of New York, that multiple state agencies came together, particularly the agency where Medicaid is housed and the Department of Corrections, in order to come up with a collaborative way to share information and put policies in place to identify if someone who's being booked in jail or prison has Medicaid or is on the Medicaid rolls. So the Department of Rehabilitation and Corrections issued a policy outlining the process for identifying inmates entering the system with active Medicaid benefits, suspending those benefits, and then restoring them upon release, or in the case of inpatient hospitalization, which we'll talk about more in a little bit. So in Ohio, within 72 hours of entry into state prison, all inmates are checked for active Medicaid benefits. Using an online database, the name of which is right here, the Reinstatement of Medicaid for Public Institution Recipients. And if they're identified as having an active Medicaid in this database, it's suspended through this portal, and then the inmate's information is entered into the ROMPERS tracking database, which is actually just an Excel spreadsheet. It sounds a lot more fancy than it is. Tracking database, Excel file, then generates a daily report of inmates who have been released following incarceration of less than 1 year and whose Medicaid benefits were previously suspended. So these individuals then have benefits reinstated through this portal. So it just keeps track of who is on the Medicaid rolls, who do we need to suspend benefits for, when is this person leaving the facility to make sure that the benefits are reinstated. It sounds pretty simple. However, as we'll talk a little bit in the implementation portion of our conversation, it has been challenging for states in terms of implementing some of the information sharing and just technological systems, databases that are required to do this. But there are states like Ohio that are using, they did develop this particular database, but then they also just keep track using Excel. So there are different levels of tracking and information sharing that are possible that don't necessarily require a really sophisticated system, although that is the ideal. There are also some federal grants I will mention as well that came out last year, and I'm not sure if they're going to re-release, but just to have that on your radar. They're grants that support information technology development within corrections or criminal justice settings. So just important to note, this is definitely on the Bureau of Justice Assistance's radar, and they're trying to help support states in implementing some of these more technology solutions. So now let's talk about New York, which is a little bit unique in the fact that they're a good example of this strategy here that I identified in the table. The length of suspension should ideally be indefinite, but is often determined by the state's policy for redetermination of Medicaid eligibility. So federal guidelines require that every 12 months the state is someone's eligibility for Medicaid is redeterminated. So states have many states have designed their suspension policies around this particular guideline so that every 12 months they'll be suspended, but only for 12 months. And then at that time, there will be the redetermination. And if they're still incarcerated, their benefits will be suspended again, and so on, depending on how long they are behind the walls. However, in New York, it's slightly different because they suspend Medicaid enrollment indefinitely. So here is the excerpt of particular interest from the New York State Social Services Law, which reads that to the extent permitted by federal law, the time during which such person is an inmate shall not be included in any calculation of when the person must recertify his or her eligibility for medical assistance in accordance with this article. So, this means that they're saving in unnecessary administrative burden associated with the redetermination process, and they can just suspend indefinitely, and what triggers the reinstatement is someone's release, and it's not necessarily adding this extra layer of going through the redetermination period for people who are in in prison most often in this scenario, because people in jail are there for shorter periods of time, typically. So in 2013, this is significant because they had about 11,000 inmates that had suspended status. And they were able to implement this law in their system to facilitate and streamline their suspension practices. What is the next frontier, though, of Medicaid suspension? So states with suspension policies in place are increasingly looking at the possibility of eliminating the need for suspension status altogether. And how would they do that? Well, it would involve putting in place an advanced information technology and data matching system to allow them to just simply avoid submitting inappropriate claims for reimbursement. So suspension is needed in the first place because states are required to comply with rules prohibiting the use of federal Medicaid dollars to pay for healthcare services for inmates of public institutions. Well, if there's a more sophisticated mechanism or of a truly integrated system in place, that would just preclude the need for suspension because states wouldn't even bill for inappropriate services, and you wouldn't need to have that protection of suspension in place. So a couple different states are looking towards this. This is something they're moving toward over time because obviously it's a very complicated process and implementation to really build up the information systems that are necessary to execute this. However, this is kind of the goal, really, the net frontier. Ohio's looking at exploring whether a system that restricts payment to certain providers and provider types for inmates could eliminate the need for suspension. And New York is moving towards a sophisticated real-time eligibility system using the state exchange, which would lead for the opportunity for them to move away from suspension and allow for a system that just makes sure that no inappropriate claims are submitted while someone is incarcerated. So just some food for thought there of where the ultimate goal could be in terms of making sure that people are still able to access Medicaid upon leaving jail and prison, but what this might mean administratively for correction systems. All right, now we're going to talk about the exclusion I've been alluding to for the past half hour. Another benefit to suspension, states can bill Medicaid for inpatient care for individuals who are incarcerated. Because community-based inpatient care represents a sizable cost of care provided to individuals in jails and prisons, there's a potential for considerable cost savings to a state that's effectively able to use Medicaid funding to finance some of these services. So to qualify for federal participation under the exclusion, An individual must be admitted to a community-based facility that is separate from the corrections department, and they must be there for at least 24 hours. But if you meet those criteria, once an individual has been admitted to this appropriate inpatient setting, all medically necessary covered services provided to that individual can be billed to Medicaid. That's pretty huge exclusion. So this allows states to receive federal matching dollars for these services. So states receive a certain percentage back. And it also results in states paying a lower rate for this care because Medicaid is generally able to negotiate more favorable reimbursement rates with hospitals than corrections departments. This is an astounding fact that I'm going to share with you. A comparison of reimbursement rates paid by two agencies of one state found that the corrections department was paying anywhere from 2 to 8 times the Medicaid rate for the same services. So this is a map of states that are already billing Medicaid for inpatient care to varying degrees. At least 14 states bill Medicaid for at least some eligible inmate inpatient care. So as I mentioned, the scope of this varies in that some states only bill for certain services, and some states are billing for every allowable service for individuals who are receive inpatient services in a community-based setting and are there for more than 24 hours. So this is a very important exclusion. And we're going to talk a little bit about what different states, I know I'm a bit sensitive to time. I think I might be running a little, am I okay? Okay, so we'll go through this relatively quickly. I apologize. I'll also make sure you have the slides, so you can have these also. But let's look at what some different states are doing with this exclusion, because it's very, very interesting opportunity. So North Carolina elected not to expand Medicaid eligibility, but they're still able to achieve cost savings by effectively using Medicaid to finance some inpatient care services, as you see here. So their state auditor found that the Department of Corrections paid more than $159.8 million for health care, and about $26.5 million of that sum was for inpatient medical care. That was provided to likely Medicaid-eligible incarcerated individuals. So they determined that if they had used this inpatient exclusion under Medicaid, they would have saved $23 million. So recognizing this, the state passed a law in 2010 that requires the DOC and the Health and Human Services Agency to develop protocols for using Medicaid to pay for care provided to those in the state that would be receiving Medicaid if not for their incarceration. And so they've been requiring under their state plan since 2011 that hospitals and other inpatient providers bill Medicaid for services provided to Medicaid-enrolled incarcerated individuals. And now this is very interesting because they're billing Medicaid directly, the providers. So it's not that corrections is billing, it's that the providers are billing directly for individuals who are incarcerated, but under this exclusion, services can be reimbursed for the services or allowable services. So what does this mean? Then you're avoiding certain administrative burdens and you're generating greater efficiency by having the providers who are billing all the time Medicaid for services. That's part of what they do. They're doing that directly. And North Carolina's reported so far that they've saved $34 million on 2,000 eligible hospitalizations, which is a significant cost savings. So now North Carolina is really actively making very concerted efforts to enroll more and more individuals when they're incarcerated. Having started with taking advantage of the inmate exclusion, they want to make sure that more and more people are enrolled on Medicaid so that they can use the exclusion for more people. Kentucky. Is anyone from Kentucky in the room? Oh, hello, sir. I'm going to talk about Kentucky's Cabinet for Health and Family Services. They projected over $1 million in savings on inpatient medical care for FY14 and over an $8 million in savings by 2021. So we've heard that in Kentucky they're looking at how to maximize the use of this inpatient exclusion for inmates. Also, another state is Michigan. The Michigan Senate Fiscal Agency estimated that billing Medicaid for eligible inmate patient care could save them as much as $12,579.500. So there's, oh my gosh, that was not a number. I'm sorry, approximately $12.5 million. There's a real number. So they could save almost that amount of money by using this inpatient care exclusion under Medicaid, so resulting in significant savings, potential significant savings. So I'm very sensitive to time, so I'm going to move relatively quickly through the last two categories here. But I'd like to turn our attention to strategies that promote the appropriate use and coordination of healthcare services once individuals are enrolled. So as I mentioned before, it's not just connecting someone with services, but it's also maximizing their ability to access appropriate services, and also that they're engaged in treatment and services. Prisons and jails spend millions, as we talked about before, to provide healthcare services to those who are incarcerated. And studies show that prisoners' health status improves as a result. But many states have invested substantial time and resources at the same time to enroll eligible inmates in Medicaid and restore their coverage. But there's going to be little return on those investments if these individuals don't access healthcare services upon release. So to help improve continuity of care, state corrections and health agencies have taken a number of steps to improve the rate at which individuals access care, both routine preventative care, and also specialty care. So we're going to talk a little bit about mental health services and substance use services. So these efforts are currently targeted towards individuals who have specific diagnoses or a specific set of diagnoses, mainly because those are the individuals who are found to be most at risk or most in need of more complex, comprehensive care. So in Massachusetts, they have made a concerted effort to target individuals who have serious mental health diagnoses prior to reentry. So the Department of Corrections arranges outpatient appointments with community providers. So that actually 24% of all male prisoners and 59% of all female prisoners are currently offered this assistance in locating and connecting with community healthcare providers. And that's just the percentage of people who qualify for this specific assistance. So there's a huge proportion of individuals who are behind the walls who could benefit from this specialized outreach, who have these mental health diagnoses or specific health needs like HIV. There's also other concerted efforts to look at people who have HIV/AIDS and connect them with services in the community as well. It's also unique because they provide training on how to appropriately access health services through the Medicaid program as part of reentry planning. So as we mentioned before, making sure that you're incorporating this into a more comprehensive discharge planning process. So they actually, a representative from Medicaid's, our Massachusetts Medicaid department comes to each institution within the DOC. I think it's twice a year. They come and meet with inmates and answer questions about health coverage and how to access care. They also have a 2-day workshop for every single inmate prior to release, within meeting this mental health diagnosis, with every single inmate who meets this criteria, that incorporates a section on health insurance, and how to access preventative and routine care. So they found that this is working because a 2011 study found that among 2,400 individuals released from DOC facilities in Massachusetts since they've implemented these strategies, 70% had a medical visit within the months following release. And this population also accessed preventative care at nearly twice the rate of the general Medicaid population. They also had a lower use of emergency services. So this is actually an effective strategy. I'm very quickly going to say a word about health homes. Medicaid health homes, they're not targeted specifically to criminal justice population, but a significant proportion of people who are involved in the criminal justice system will qualify for services under the Medicaid health home inclusion criteria. And that specific criteria is individuals with at least 2 chronic conditions, 1 chronic condition and at risk of having a second chronic condition, or 1 serious and persistent mental health disorder. So as you can imagine, a lot of people who are leaving jails and prisons are going to qualify for services under the Medicaid health home inclusion. And so states also that elect to implement this model receive enhanced matching rates. It's authorized by the ACA as an option for all states, regardless of whether a state is expanding Medicaid eligibility. So to date, 15 states have approved Medicaid state plan amendments for a health home or models, and another 11 states have received planning grants to implement health homes. I'm going to talk very quickly about New York State because they're doing a health home demonstration project, which is particularly interesting in terms of criminal justice and corrections because they are looking very specifically at the relevance of the health home model for those who are involved in the criminal justice system. So they have a criminal justice committee that's looking at the application of health homes for this population, and they're actually going to be collecting measures, which is very exciting, to assess criminal justice impact. So what impact could connecting individuals with health homes have on recidivism? We don't know, but we're very excited to learn from New York what implications the health home model might have for this population. And finally, I'd like to highlight a couple of financial opportunities. We've already talked about billing Medicaid for inmate and patient care, but I did want to just put it here because it falls very neatly under this category. So Department of Corrections should explore whether they can rely on Medicaid-covered services instead of funding mental health and substance use services for parolees. In order to draw down federal match funds. So who's looking at this? California is currently looking at how to identify sufficient behavioral health providers. So they're trying to identify providers in the community who participate in Medicaid, who would be able to serve parolees, and that would save a considerable amount of money for Department of Corrections and the state as a whole. Also, I believe Michigan is also looking into this. They had a Senate fiscal agency their Senate fiscal agency estimated it would save the state in excess of $8 million by eliminating corrections funding substance abuse testing and treatment services, and instead directing individuals to services covered by Medicaid or private plans. And also, as I mentioned here, billing Medicaid for allowable community-based inpatient care for individuals who are incarcerated is another very exciting financial opportunity. System implementation considerations. So where the rubber meets the road a little bit. So with all of these people who are going to be enrolled, what does this actually mean in terms of making sure that they're connected with services and they're accessing those services? So there's some areas here that we're looking at in more detail. I unfortunately could have a whole other session on these specific implementation considerations, and we don't have time for that. But I wanted to just give you a sense of what implications some of these strategies have on systems. So the availability of quality care associated with good outcomes. So we know what evidence-based and promising practices and programs have good outcomes for people who are involved in the criminal justice system, particularly those who have mental disorders and substance use disorders. So are people going to be connected with this quality care that results in the most positive outcomes? And is this care going to be covered under essential benefit packages? So all newly eligible Medicaid beneficiaries under expansion will be enrolled in plans whose coverage must include 10 categories of essential health benefits, which represents a significant opportunity to improve access to mental health and substance use care. But unfortunately, we don't have much guidance, and CMS has yet to release guidance on what exactly the services need to be under these 10 essential categories. So it could be a very good opportunity to connect people with mental health and substance use care, and also Oh, I'm sorry. Yes, but we don't know exactly what services are going to be mandated to be covered. So that's an open question now. And just the pure fact of, are these services even available in the community? I mean, we hear from a lot of different communities across the country. Rural communities struggle with different access to resources, and urban communities struggle also with, maybe identifying quality care within their myriad of services. So there's lots of different issues that states and communities are struggling with in terms of what services they have to offer. So, what can they actually provide? Provider capacity and network adequacy. This is a big question that we don't really know yet what the implications of enrolling individuals is going to be. But what is the capacity of providers who are participating in Medicaid? That's a very important distinction. Those that are actually participating, because there could be a lot of providers that aren't participating in Medicaid that have elected not to. So what is the capacity of those providers who are participating in Medicaid to serve these individuals? Are plans complying with the parity requirements? I don't know if you've heard about parity yet in your other presentations, but parity requires that that substance use and mental health services are as accessible as medical services. And unfortunately, this is not something that is monitored by the federal government, so this is really a responsibility of states to develop ways to monitor plans' compliance with this parity requirement so that people can access mental health care and substance use care at the same level of medical care. Potential mismatch between covered services and expectations of judges and prosecutors. This is very specific to the criminal justice field. But as an example of this is that there may be exclusions on coverage of court-mandated treatment or treatment that's a condition of probation or parole. So a judge might require that someone participate in a certain treatment program as part of their parole conditions or probation conditions, but that's not something that is covered by Medicaid, and that individual doesn't really have any other way of paying for those services. So what does that mean in terms of communicating expectations with the criminal justice system in terms of how they're using treatment as a mechanism, as a supervision requirement mechanism. And information sharing, as I mentioned before. There's a lot of implications that come up on how to best share information across different agencies and avoid duplication and make sure that the policies we're putting in place are maximizing efficiency. So very quickly, a couple resources. This is a resource that, as I mentioned before, these evidence-based practices and programs that we know have good outcomes for people who are justice involved with behavioral health disorders. We put together a checklist that gives more information on those particular programs and practices. And then this document that you have is in your handout, as a handout. I please urge you to read that or consult it. And yes, that concludes my presentation this morning. Thank you so much for your patience and your attention this morning, and I hope you have a wonderful rest of your day today.
We talked primarily about Medicaid here. For states that don't expand, the federal government provides subsidies to individuals down to 100% of the federal poverty level, and will subsidize up to 98% of their costs down to 100%. Do they lose those subsidies if they're in prison?
They're not, right. They're not able, under the marketplace plans, you mean?
The marketplace plan.
Oh, that's a good question. I don't think that they can bill for those services when they're incarcerated, even if it's under a marketplace plan.
So if I lose my subsidy under the marketplace plan, I'm only going to lose my plan. So there would be no billing for the services at all. So they would lose their plan. So the flip side of that is when they're released from prison, does that constitute under the ACA a a significant life change that would allow them to enroll at a time other than the enrollment period?
That is an excellent question, and I'm afraid I don't know the answer off the top of my head, but I will look into that because that's a fantastic question. Actually, if I could get your information, I can follow up with you separately, if that's okay. So what are the implications of incarceration on enrollment in the Marketplace Plan, and would they be able to enroll in plans for individuals who weren't previously enrolled following release to the community? That's an excellent question. Yes, ma'am.
Well, I guess just as a follow-up to that question is, if the people are, in prison, and as you said, most are either suspended or terminated during that time period, how do they access that exclusion of being able to be treated in the 24-hour?
So that is an exclusion that the correction system would take advantage of. So they would recoup, so they would pay for someone's care if they're receiving inpatient services while they're an inmate in a community-based setting, and that's something that they would pay for, and that they would then recoup the money from Medicaid for those services.
Oh, wouldn't the person that they were getting the money for have to be on the Medicaid system in order to?
Yes. So they would have to have suspended benefits because they would have to be able to bill Medicaid for that person's services. I'm sorry, maybe I misunderstood your question. So they would have to be enrolled, but it would either need to be suspended so that no other care is billed for, only the allowable services under this exclusion, or, as I mentioned before, they would need to have some kind of sophisticated system that would only allow for billing for those allowable services, but they would still need to have an active Medicaid enrollment. So either way, they would need to be enrolled in Medicaid, whether or not it's suspended or if they have some kind of mechanism in the state to make sure that only those allowable services are billed for, so they're not violating the federal rules on billing Medicaid for services other than these inpatient services for individuals who are incarcerated.
So,
does that make sense?
Well, so what you're saying is that people that are incarcerated can remain on active Medicaid?
Yes. But you can only bill for these allowable services under the inpatient exclusion. Is the only time you can bill Medicaid for any services for someone who is in jail or prison, who is incarcerated. It's only under this exclusion that you could bill Medicaid. But if they're not enrolled in Medicaid, then you wouldn't be able to use the inmate exclusion because you wouldn't be able to bill Medicaid for people who are incarcerated. So it's kind of a specific exclusion with only allowable services under that provision, but you would still be able to recoup those savings, which is better than recouping no savings because the inpatient hospitalization or inpatient care are often most expensive. So you would be recouping cost savings in that way. So it would be a benefit to make sure that people are all enrolled upon entering jail or prison, that they're already on the roll so you could take advantage of the exclusion.
I guess that went back to how you led into the discussion was that I thought it was that tax dollars couldn't be expended on people that were incarcerated.
Absolutely right, except for this one very specific use of dollars. It's only under this exclusion for these inpatient services that are delivered in a community-based setting that is separate from corrections, and they have to have been there for 24 hours. That's the only time you could possibly bill Medicaid for services for individuals who are incarcerated. Yes, absolutely.
So if an inmate's appendix bursts and they've got to be hospitalized,
right.
They send them to the local hospital. If they're enrolled in Medicaid and they're there more than 24 hours,
yep.
Instead of corrections paying for that hospitalization, Medicaid pays for it under whatever your state match arrangement is with Medicaid.
Yep.
So you save
yep.
money.
And you get a better rate by billing Medicaid for those services, which is significant because if you're paying you're paying some portion of it, most likely under the match. I don't know exactly what the match amount is, but it would be less if the overall amount charged or billed was less. So thus, that is benefit to you as also. Yes?
To be clear,
Yes.
in terms of who is billing Medicare, I thought that you said that the provider bills Medicare directly, not Department of Corrections.
Some states do it both ways.
Okay.
So North Carolina, absolutely, you're right. North Carolina is interesting in that they do have the provider bill directly, which is actually better than having corrections bill because obviously it has to go through that different administrative step. So that is more of the ideal. But some states do have corrections. Corrections does bill. Or the health provider that corrections has contracted. Yes?
Can you talk a little bit about these Medicaid health homes? I mean, is that like
Sure.
a halfway house situation, or what are we looking at?
No, it's actually, the term health home makes it sound like it's a physical brick and mortar, only one stop. It's actually more of a conceptual idea that some facilities may have all of their services within one roof, but others, it's really just a way to enhance that coordination and make sure that under billing, you're able to bill and pay for these more comprehensive services, having this more holistic approach. But it could be a series of agencies that are contracted to develop or to deliver services under this under this health home inclusion. So it's more of a mechanism to help them provide services to people in a coordinated way and to be able to bill for them rather than having a physical brick and mortar one-stop shop.
We're going to have a speaker this afternoon that's going to cover this topic in
Yes.
detail and give you some examples, just like Alex did in the corrections space.
Great.
One more question. Gail's hand was up first,
Oh, sorry.
and then we'll take Dr. Goldie's questions as well.
Yes, ma'am.
Well, in the state of Kansas, we have a provider that, has contracted with us for a certain amount to provide all of our medical care for our inmates. I was wondering, those companies, they seem like they specialize all across the country going to these different correctional facilities. I'm sure they're aware of this. When they're negotiating their contracts with our Department of Corrections, surely they are aware of this. Do you think that they have already incorporated that? Or, are they using that as a negotiating tactic?
That is a really good question. I don't know. I don't know if that's something that's built into contracts. It might need to be something that's explicitly discussed with providers to see whether they are billing for that, because some of the providers actually may not know that they could bill for this under this exclusion for this particular population. So, because it does require more of coordination on their part to make sure that they're identifying the allowable services that they could bill for. But that's a really good question. I don't know. And actually, I would like to circle back with some of the states we had at our meeting as follow-up to see how they've done that with private providers that they're contracting with, because I don't actually know how if they've explicitly laid that out as you must bill using this inpatient exclusion for the following services. That seems like it would be a logical thing to include as part of your contracts. It should be featured in the negotiations. Sure. Yeah, absolutely. Yes, sir.
I'm still confused on the exclusion a little bit. You said that they had to be Medicaid eligible
Yes.
before, but we looked at North Carolina. North Carolina has not expanded its Medicaid program, so essentially males are not eligible for Medicaid, which is the largest part of the prison population. So they would never be eligible for Medicaid when you go in.
Well, unless they have a serious mental illness or some other disability, then in which case they would qualify if they receive SSI or SSDI, they could apply and they could receive services under Medicaid. So in North Carolina, yes. Yes. Where is my slide? I've lost it. Yes, so they are they're enrolling people and using the exclusion under the current Medicaid parameters, but they still were able to identify more people who were eligible. Sorry, I completely bypassed this. More eligible inmates than they had anticipated even without the expansion. That would be an example, yeah, of someone who could benefit from this.
You have Alex's contact information?
Yes, indeed, and I have cards, and I'll leave some here.
Her email is next to her name in the speaker list.
And I'll leave some business cards with you, Deborah, just in case.
Sure.
Okay, great.
So feel free to get a hold of her. She's part of the CSG family. So
Yes, especially for those very interesting questions your questions specifically. I want to look into that. Thank you so much.
It's going to take us about 2 or 3 minutes to switch speakers, and the bathrooms are right across the hallway, and we'll get going in just a second.
He lives in South Carolina. Yeah, he lives in,
You don't hear all the flashes, Mom. Well, but apparently this is and the heat goes in spring, goes up in
Thank you very much.
Even negotiate that with our
with a private health
And I
provider.
remember, I don't remember seeing that. It's one of the national, I can't think of it. It's me,
Private maybe or something.
There was
So
correct.
it's a private.
Yeah, so surely over.
It's a really good question. Well, actually, no. If they got into automatically out you would think, absolutely.
They would lower their costs.
I don't know.
Whether the states figured it out or not, it would lower their costs because they would pay for them. They gotta figure out the Medicaid.
Well, that's good. So you find out if they're doing that.
That's Mary's short one. Get all that down?
Thank you for having me. Yes, absolutely.
And also, we need to get. I know
We have examples.
So we'll do that.
Absolutely. And
I
actually,
will get you down, Mary,
Yep.
and then I need to get my dentist on, so.
we could identify different examples that have different levels of direction. So some that are like through the sort of directive.
Well, there gotta be, state law.
Well, right.
For this process.
Okay. Because there's obviously different
States that.
Got it. That we can definitely
All right. So that's Mary.
Okay, so I go this way. Thank you so much, Deborah.
Okay, if we can sort of get situated again, please.
Just like having a job on the caucus with, trying to organize lawmakers.
Well, I was about ready to threaten that my fire hose is going to get the folks who are standing up, but okay. We're going to switch gears a little here for this next presentation. Like the one we just heard, it's the intersection of Medicaid and something. In this case, the intersection is Medicaid and oral health. And again, as we listened yesterday, oral health came up as a question we asked for your all's benefit. We asked legislators who are in attendance here to give us an idea of what one question they want answered before they go home, and how to use Medicaid or better use Medicaid to meet oral health needs in their state was a question on at least one person's mind. I won't name names, but so today with us we have two representatives from the American Dental Association. John Holtze, who's standing here in front of the screen, is the Director of State Governmental Affairs, and he has worked in the state legislature in Illinois for 14 years, including 7 years with the Speaker of the House. So he's familiar very much with the pressures that you all face in a daily basis as a state legislator. And Paul O'Connor is with him, who is a legislative liaison with the American Dental Association. And they've got some slides to go through, and then I'll have time for some discussion and question and answers.
Thank you, Deborah. We're thrilled to have the opportunity to be here with you today. I know that as you dive into Medicaid and just healthcare as a broader issue, that, you know, it at times can seem like an endless morass because of the complexity and the depth of the issues that you're dealing with. And especially if you're coming to it, you know, from a profession as a teacher or a firefighter or an insurance agent or, you know, whatever, that was not your expertise. It can be daunting at times. But I commend you for taking this deep dive. And again, thank you for the opportunity to be with you here today. You know, I'm pleased to hear that the question of how do we address oral health within Medicaid came up from this group, because too often it's an afterthought when we're dealing with health systems as a whole or health systems specifically within Medicaid. And that there are some consequences to that. The consequences being that untreated dental decay or dental disease period, whether it's infection, decay, whatever the case might be, is the most common recurring disease in kids in our country. And that's a problem. You know, it means school isn't attended on too many days. It means that when the child does get to school, they may not be paying attention or absorbing as much as they possibly can. And especially when we're talking about the Medicaid population, if we're ultimately going to break the cycle of poverty, that has real consequences over the course of time. If the child can't learn, then ultimately they're not going to succeed, and that's a problem for all of us in society as a whole. Same thing for adults, because whether it is time lost from work, whether it's an employability factor in the first place, just think about yourself as an employer. If you have two different candidates who are relatively equal in all ways, one has the mouthful of teeth that look absolutely normal, The other one is missing a lot, doesn't have the prosthetics to replace those. There's functionality on nutrition, there's presentation to the public and consumer skills, those sorts of things. It does have an impact. And so it's important for us to pay attention to this and ultimately look for solutions going forward. So one of the reasons that oral health can be marginalized is because in the overall spending of what we do as consumers in healthcare in this country, and especially within the Medicaid system, it's just over 2% of the Medicaid spending across the country that is dedicated to oral health. And so when you're looking at places to capture savings, to capture efficiencies, it's not necessarily, the bright light that is screaming at you. But the consequences that I just talked about do cascade over time to a host of different things. And as strangely science is discovering today, the mouth is in fact part of the body. And there are impacts between oral health and overall systemic health, whether it's heart disease, diabetes, ultimately nutrition, obviously, those sorts of things we have to pay attention to. So just over 2%, not a lot, but those pennies do add up. This next bullet, I did this intentionally to make a point. The current percentage of dental services delivered via Medicaid. And I'd ask Paul to explain that just a little bit more deeply.
Right. And I'll just stand up from here and speak a little more loudly rather than fight my way across. When John was putting this together, one of the questions that came up was, what percentage of all Medicaid or
what percentage of dental services are delivered via Medicaid?
Thank you.
Yeah.
That's what it was. I couldn't remember the question. But I thought, well, that should be pretty easy to answer because, when you're a dentist and you have a Medicaid patient in, this package of services are Medicaid services. You have a private pay or out-of-pocket paying patient come in, and then that is categorized differently. So I thought certainly it would be easy to find that percentage of how many services are done in the Medicaid realm. Could not find that anywhere. So I thought, okay, well, I should go to the experts. We have a group of folks, the bean counters, as I call them. They know how to dig these things, do the research. So I checked with them. They couldn't find it either. So I think the point that jumps out from this one for me is sometimes in order to know how you're doing, you need to know where you are. And if you can't find out where you are, that makes it difficult to know if you're improving or not, or things are getting worse or not. So this is a good example of sometimes it's difficult to get some good data from some of the state Medicaid and also from CMS at the federal level. So I thought that was a really good point.
Yeah, and so one of the takeaways to the question of how do we improve the delivery system for oral health and Medicaid is when you're looking at it, data collection is vital. Especially when we're talking about vast sums of money like we are within a system that large. It's important to be able to analyze that data to understand what the outcomes are, what is being effective, what is not being effective, so that you ultimately can make informed choices about what those coverages and packages are going to be, what's effective spending for you and the enrollee. So that's an ask. Another impact more recently is that of the Affordable Care Act, and I'm sure you've heard that many times over the course of these couple of days here. But in dentistry, it's the very same. But our impact on ACA is actually turning out to be a little bit different than we anticipated at the time that it was enacted. When we're talking about dental Medicaid, obviously each state system is different because you have that flexibility. But the feds do require that for those under the age of 21, that there is an oral health benefit under the EPSDT, Early Periodic Screening, Diagnosis and Treatment requirement of the Social Security Medicaid Act. And so for children, The fact that they have coverage if they are Medicaid eligible is universal across the country. For adults, it is much more of a patchwork. And there are states with absolutely no adult benefit. There are many with primarily emergency benefit. There are some, and the good news is we'll describe an increasing number that are expanding those benefits to adults because they're seeing what the long-term outcomes can be. But that is a real hole in those systems. So when we looked at this, we thought, okay, well, because so few states have a comprehensive adult package, even if a state decides to expand their Medicaid eligibility, the adult impact may not be all that large. It would probably be within the population of children that we see the expansion. However, the vast majority of states had already done substantial eligibility increases on FPL for the required EPSDT child populations. Therefore, the impact, even if a state took the expansion, has not been that significant with the children. Where we're seeing the growth is actually in the adult population, and we'll talk about that a bit more shortly. So what we could find out of the data is that 8% of dental spending nationwide was funded via Medicaid and other public programs. We couldn't get the delineation out, so you've got a little bit of CHIP in there as well. But those are the two primary programs, with Medicaid being the vastly larger of those programs. And there are a few states with some general assistance coverages and that sort of thing, but those are minuscule. So, probably 7% of that nationwide is Medicaid spending. But what percentage of procedures that are done, we'd love to know. Ultimately, this will be increasing. I talked about the benchmarks for children. They're relatively low, 133% of FPL for those under the age of 6, 100% of FPL over the age of 6. But like I said, the vast majority of states have made significant increases for that for young populations. The expansion that we're seeing and the estimates are that ultimately, as states both expand their Medicaid eligibility for adults and more recently, turning the pendulum that had been slashing adult benefits, we're starting to see a turn as the economy has recovered some, tax revenue has increased, and some of the losses to the recession to state budgets have been recovered. We're starting to see a turn. And so in the last couple of years, several states, including Washington, Colorado, California, Illinois, and Missouri, have made substantial either restorations to adult Medicaid coverage or instituted it for the first time in a state like Colorado. And that is a real sea change compared to where we had been over the last several years. And looking at the population, California, Illinois, are large states, Colorado, Missouri, and Washington, all mid-sized states. That's a lot of people potentially coming into the system. So that's where our growth is occurring at this point in time. But as much as we'd like everything to be sunny and rosy and all of that sort of thing, obviously these are human programs, and we encounter difficulties just like any organization will with anything that we endeavor. From the patient side, the most common barriers to them, even if they have the coverage under Medicaid, the most common barriers preventing them from utilizing it are A, financing, not knowing that they have the coverage, or if they are enrolled as an adult, not having state coverages there, and therefore it's out of pocket for them, and the affordability factor is a real issue. Knowledge, oral health literacy, the understanding of the importance of oral health to overall health, and that there is a real gap. And don't think that folks under Medicaid are that much different than the population as a whole. These two things are the primary barriers, whether someone is in upper income, middle income, or lower income brackets. It's something we see relatively universally across the country. Other barriers for folks are if they, sometimes the employment situation is such that if they need to get something taken care of, work can be a challenge to arrange the time off to be able to get that treatment. Childcare issues, whether it's, bringing kids to the office, arranging care for kids outside of that visit, all of those sorts of things, transportation issues, reliable transportation issues, truancy. One of the things I've heard several times are, the kids have missed X amount of school, and, there are several states that are very strict on their truancy laws, and some triggers after X number of days kick in with penalties toward the parents if the kids are gone without acceptable cause. And the parent will say, I know my child needs this, but I don't want him to miss school again. That's a real problem. And network adequacy. Obviously, whether it's administered directly by the state, that is responsible for the development and fostering of the network of providers who are enrolled in Medicaid, or if it's contracted out to a third party. The adequacy of the network is a vital issue, and that goes into the conversation about some of the barriers of why practitioners may not sign up to be Medicaid providers. And those issues include reimbursement. I know it's a tough nut for policymakers because you have the conflicting pressures of balancing a budget and providing services to a broad swath of individuals. That's an inherently difficult thing to pull off. And so where are those intersections? Well, it's on the administrative costs, it's on the reimbursement to the providers, what the coverages may be, what the benefit package may be, those sorts of things. And too often, as the reimbursement declines, or more commonly is just static over a period of time and loses relevancy to the marketplace, you will see a marked decline in the number of individuals who enroll to be providers, because ultimately, if they're not recovering their overhead, which for a dental practice is usually somewhere around 2/3 of each patient that comes through the door, it's a loss for the practice overall, and it becomes a very difficult burden for them to deal with. Administrative burdens. We certainly recognize that with large entities, bureaucracy, red tape can become issues at times. And there are different states with different models out there, some of them very cooperative and very educationally oriented toward the provider, and easy to access to get information, have issues resolved. There are others that are, much more the stereotypical bureaucratic situation that you might think of, and that does play into whether or not somebody makes the conscious decision to sign up to provide within that system. Carve-out. And for those not familiar with that term, when we talk about carve-out within Medicaid, it means for dental that the administrator for the dental Medicaid system is specifically an entity that is experienced in direct delivery of dental benefit and dental benefit coverages. So it is not necessarily your overall managed care plan that is the third-party administrator for overall health care within the state. But instead, it is a group that is specifically designed to deliver dental benefits and understand the nuances and the difficulties that that specific segment of health care encounters. over the course of time, we found it to be a relatively effective methodology to do two things. One, streamline the system, cut down some of that red tape, but also create a spirit of cooperativeness within the provider community, because they are much more confident when it is somebody, for lack of a better phrase, speaking their language. They're much more attuned to it and have an affinity for it, as opposed to a system that they normally would not be dealing with. Audits. Certainly, we all understand the importance of program integrity and accountability within the system. We're all taxpayers. We need that, and as citizens, we demand it. On the other hand, there needs to be due process for the provider when that comes into play. And we've had an experience recently with the implementation of ACA that has made this a more critical issue. And I'd ask Paul to elaborate on that just a bit.
Sure, thanks, John. Within the ACA, each state, as my understanding, is required to have a recovery audit contractor on retainer to do audits within the states, in addition to what the state Medicaid audit program integrity unit might be doing in that state. As John had alluded, one of the biggest concerns is you have some states that have made some real progress in moving the needle, improving the program so dentists can feel more comfortable being able to provide services for the Medicaid population. And when some of the audits, for some reason now, I've been appointed the person to collect the phone calls, concerns from the folks out in the field. So I don't know what I did, but I'm the one that called. And almost without fail, when I get those communications and ask the dentist if they could explain what happened, they end that conversation with, this just might be the straw that breaks the camel's back. It's just too onerous a program. I'm not sure I'm going to be able to stay on as a provider in the network. I want to be real clear as we talk about this, not proposing that the audit and the program integrity process is key and important to Medicaid. There are bad players out there in all the professions of Medicaid, certainly that is the case, but looking for some due process, things like that. We've communicated with CMS, the Centers for Medicare and Medicaid Services, with some of the views that we think are important with the audit topic. I think you can also take it down to state legislation. We have at least one state that has maybe try to put some common sense parameters around the audit process program. So I can share that somewhere along the way if anyone's interested. But the biggest concern is what it might do to the provider network.
Thanks, Paul. And, from our perspective, for the most part, we'd like to avoid the legislative process on resolving an issue like this because, in all honesty, it's much more of an administrative duty, and talking to people can oftentimes lead to a better understanding and better systems to promote and encourage compliance. However, if that is unsuccessful, then the only remedy that one has to potentially seek resolution is to the legislature, and ultimately that's what occurred in the state of Connecticut. That's the state that has enacted something this legislative year requiring and establishing parameters around this. And so it's just a burgeoning issue that we wanted to draw a little bit of attention to with you here today. Not expecting everybody to go running out and making phone calls to your drafting staff to have something drawn up for next week, but I just wanted to put it on your radar so that you're aware of that occurring. And ultimately, compliance as a whole. Again, it's important that it is a cooperative, collaborative system with the provider network so that the providers understand what is required of them and that there are not errors of, omission or errors of, just ignorance that would trigger a more invasive audit process and recovery process that, in fact, is probably justified from the state because something was not occurring. But on the other hand, the provider feels, kind of put upon and singled out because Nobody ever told me this. So it's a two-way street, and there are states that are very good at this, and would encourage folks to contemplate that as an important part that's primarily non-financial as far as making the system more seamless for all. Financing. Obviously, always with any program, that's a huge thing. And I put 50-50 up here for two different reasons. One, of course, because it's a shared funding stream between the feds and the states, although 50-50 is not the match, as you're well aware. I just wanted to remind us all that it is a shared program. Secondly, when looking at reimbursement rates and into the provider network, and especially when we're talking about the most common and especially preventive procedures, because ultimately everyone's desire here is, for the most part, dental disease is preventable. And so if we can prevent the disease from happening, in the long run, we save dollars and we have better health outcomes for everyone over the course of time. But 50-50 means that if your reimbursement rate is 50% of the marketplace rate for Medicaid, well, the odds are you're probably going to have about half the dentists signed up as providers within that network. Well, unfortunately, there are states somewhere in the 20s. So imagine the lack of robust networks in those parts of the world. There are other places where it is very similar to marketplace reimbursement, and guess what? You tend to have very robust networks there where it is very, very straightforward for a patient to seek care and find a provider and not have to make the series of phone calls to find someone who A, takes Medicaid, and B, has an opening for a Medicaid patient, and C, if it's a new patient, even more difficult. And as lawmakers, I've heard many times that that's a call that their office gets, looking for someone to serve as an ombudsman to help facilitate that contact for that constituent and patient. And so, just be mindful the sort of network you have, and whether your phone is ringing or not, to seek help with those sorts of issues. Some of that is very much dependent upon where your rates are set within the marketplace. Ease of enrollment. Ease of enrollment, obviously that's a patient issue as far as knowing that the benefit is there to be able to take advantage of it and utilize it, and B, it's an issue for the providers because of the fact that great example, many years ago now, because I'm old, state of Texas had its enrollment process for dentists coming into the Medicaid system. The application that the doc had to fill out was over 50 pages long. That is not only a significant investment of time, it's just, if you're doing an online survey and it's too long, you click off the thing because I don't want to deal with this. It's just human nature. Took a couple of years of discussion with the Medicaid agency, but ultimately that was winnowed down to 5 pages. These are the days before computers, back when we were actually using pens and pencils. But that changed the game. It was much less daunting for an individual who says, maybe it's not going to be the preponderance of my practice, but, I want to give back. I want to do something for my community, and I want to enroll and help those that I can. And, okay, this looks like something reasonable to do as opposed to the stack of papers. Administrative systems. Again, we talked about the carve-out, the dedicated dental administrator. That really does make a cultural difference for the dentists. They have an affinity for those who speak their language and understand the systems that they work within. And so I can't stress that enough. It is a very important consideration. Even if you don't go to the full carve-out, perhaps a section within your administrator's workshop that is dental specific, so that expertise within that administrator's office develops over the course of time. And the right help. Just like any profession, there are the scope issues within dentistry, and finding the right help and the right extension to be able to extend care out into the community, and especially that preventive care and the education component is vital. One of the things that we're working on right now, we did a 3-year pilot project creating the Community Dental Health Coordinator, which is an outgrowth of community health representatives. And this individual can do preventive services out in the community, but is also an education conduit for patients and groups, and additionally is skilled at working with patients to overcome the barriers of care, whether it is the financing issues, the enrollment issues, the issues of transportation, child care, understanding the importance of oral health to your overall systemic health. And the outcomes within that program have been marked. The only state that has brought it into their Practice Act currently is New Mexico, and they will be opening the first educational program there. We are very hopeful this fall in Albuquerque, and look forward to that being a valuable tool that, not only organizations like federally qualified health clinics that are safety net clinics can utilize to bring people in to get them the care that they need, but even private practices could utilize, whether individually or pooling 3 or 4 practices together to employ a person like this to provide that outreach and those services to a broader swath of the community than receive them today. So, as with anything, we've talked about there are issues, there are problems. And for a period of time, the dental profession as a whole, not individuals, but the profession as a whole, as an organization, was very much in the reactive mode to working on these sorts of issues. Okay, we identify a problem, let's see what we can do to fix it, that sort of thing. Well, in May of 2013, we launched a new campaign called Action for Dental Health, or ADH in the in-house parlance of acronyms. And it's designed to do 3 primary things. Provide care now to those in need. And the primary initiatives under that heading is to extend, first of all, affordability. Folks can't afford it, so we've been enhancing across the nation efforts like Give Kids a Smile, where free treatment is provided to kids most normally in the month of February, but it's kind of grown so that it's, in many places, it's a rolling event. Missions of Mercy, you may have seen them in your communities where they'll come into like a fairground for a couple of days and provide care, first come, first serve to those in need. Is this a solution to providing care to those in need? No, of course it isn't. But it is something we can do to help triage the problem. And secondly, it is something that we can do to draw attention to the problem that exists out there, that we need more help from you as policymakers and from our society as a whole to help solve these issues of folks in need for oral health care. Elder care. With the graying of the baby boomers like me, this is becoming a larger and larger issue. And as you can imagine, especially for those who are in a more institutionalized setting, if there is not a good level of quality of care, their oral health could very easily be something that slips and ultimately causing infection, decay, the loss of teeth, all of those sorts of things that occur. And one of the things we've started to educate our members about is a mechanism within Medicaid called incurred medical expense that has been primarily used for things like vision care and that sort of thing for an institutionalized patient who's elderly. And what it allows is is that facility to reimburse the provider at relatively market rates for the services that they provide, but then apply back to the state for reimbursement of those services to make sure that this person is getting the comprehensive care across the board that they need that may not be normally a part of an adult Medicaid benefit package. And then lastly, under this one, we've introduced H.R. 43 395, the Action for Dental Health bill in Congress this year. And what we're seeking there is just some seed money to help fund some of the pilots to demonstrate what some of these initiatives can ultimately bear over the course of time. The second primary goal is to strengthen and expand the safety net. Unfortunately, over the last 25, 30 years, we have seen a serious erosion in some of the infrastructure of the oral health safety net. We've seen the elimination of many of the HRSA regional offices that were in existence for assisting states with their public health infrastructure on oral health. The good news there is that we have seen the expansion of the federally qualified health centers, and within the last decade or so, they now have a requirement for when there is new construction or a new clinic developed that they have to have a dental component arranged with it. And so we're looking to increase and improve public coverages, whether through that system or through a system like Medicaid, so that it's more workable for all and we can deliver more care. And ultimately, with the public clinics, one of the ways that they can comply with the dental requirement, they don't necessarily have to build an operatory within that clinic facility if there's not the space or the functionality to make that work. They can contract with dentists in the community to say, hey, we'll run the paperwork, we'll deal with all of that rigmarole. You just, we'll refer the patients to you, you treat the patients, and it kind of becomes a seamless way to integrate that Medicaid or public coverage into an existing private practice. And we've seen an increasing level of success with that methodology. And lastly, education and disease prevention. Obviously, if we prevent the disease in the first place, everyone is better off. Community water fluoridation, it's been around for over 60 years now, and the CDC called it one of the 10 great public health innovations of the 20th century. Certainly, I know you're aware that it is not an uncontroversial issue when it comes up, but I'm here to tell you that ask any dentist you talk to virtually, and if they have worked in a community with community water fluoridation versus a community without, they will tell you the health of the fluoridated systems are markedly better than those without the benefit of community water fluoridation. And ultimately, from a bang for the buck perspective, again, the CDC estimates that for every dollar spent on community water fluoridation, $38 of treatment is avoided. That is a real return on investment. Lastly, and I heard the individual who was here before talking about the impacts on the prison system, ER interventions. We're all certainly aware that too often when folks aren't aware of either how to utilize the system and to get the care that they need, or B, don't have the coverage to provide or finance the care that they need, they will show up and present at an ER where at least they are required to look at them and give them some sort of treatment. Problem is, that's an expensive encounter as compared to an encounter at a dental office where things are much more comprehensive in the treatment system. And secondly, the ER is not set up to deliver dental care. It's a problem. What can they do? Well, there are exceptions, of course, but for the most part, they can A, provide antibiotics if there's an infection, B, provide painkillers if there is pain, and C, say, go see your dentist. That's not a system of care. That's a problem. And it's an expensive problem for us as a society. And so we are working with several states across the nation, Maryland, Maine, Colorado, and there are Washington, and there are others where we're working to not only develop pilots, but even look further out into what that system of referral can be when somebody presents at the ER, so that A, the person can get a much more affordable and sustainable treatment for that problem that they have, and secondly, the recidivism of the, okay, well, we got the infection under control, now a month later it recurs again and we're back, a month later it occurs again and we're back, does not occur. We want to bring those numbers down. Just to demonstrate the depth of this problem, in 2000, 1.1 million people presented in emergency rooms with dental conditions for treatment. 10 years later, that was 2.1 million. That's a trend we cannot sustain. So we as society and we as a profession have to be vested in this to make it work better than it does today. And I already talked about the community dental health coordinators. I won't belabor that. The last point under here is collaboration with other healthcare professionals. With physicians, a pediatrician might see a patient that a dentist doesn't, or vice versa, or a nurse practitioner, or a PA, whatever the case might be. It's important that there's a discussion, education, and collaboration back and forth, and we're trying to really enhance those methodologies. So, the good news is that for kids, we've made some significant progress over time. Are we where we want to be? No, we're not, but it is at least moving in the right direction. Utilization of dental services for kids who were covered in 2001 was 43.2%. As of 2010, it was 46.3%, and in fact today it's a little bit higher, but I didn't have, it's for the policy people, they hadn't signed off and dotted the I's and crossed the T's yet. So that's an appropriate trend, and in fact in many jurisdictions utilization within the Medicaid population is equal to, or even in a couple of states above, that of the population as a whole. Is that ideal? No. But is it a real achievement? Yes, it is. But the downside, adult utilization is declining, and that's for a couple of different reasons. One, the recession cut in benefit packages that we experienced. And secondly, when you're young, you think you're bulletproof and you ignore many of the health concerns that you really should be taking care of, but it is within those young adults that we have seen this steep decline in utilization. So that's a concern, and it's something we need to figure out. So for kids, the benefit package has improved, the service is slowly increasing over time. For adults, that has not been the case. We've already talked about some of the impacts and the consequences, so I won't belabor that. I just wanted to show you, for Action for Dental Health, we've created a dedicated website for that. So if you're interested in any of the initiatives or programs that I've talked about, or have ideas for other ones, obviously your state dental society is a great resource, but this is out there as well, and there's the website for it, ada.org/action. So with that, I will shut up, because I'm sure I bored you to tears, but thank you for the opportunity, and if you have time, Paul and I would be thrilled to take any questions you might have.
Time for one or two questions.
Hey, John.
Yes, sir.
Yeah, Paul from Arizona. We don't offer adult dental for our Medicaid population. Is there a way to get state-specific numbers on how much that would cost, and or emergency dental?
Yeah, if we'll touch base and get your information. Paul's the guy who can track that down for you. Absolutely. We'd be happy to do that. Well, yes, sir.
It's not so much a question as it is just kind of a thought. And in Florida, we went through a massive revamp of our Medicaid program that's rolling out now. And we did a pilot a number of years ago.
Yep.
And one of the things that we found, which is demonstrated by your numbers, talking about children and ER visits, our pilot program kind of revolves around our providers being innovative and creative and coming up with ways to manage people's care.
Right.
And what they found is that they would see a kid on Wednesday, kid was in for whatever, and everything was fine. The care coordinator would follow up with them, and then they would come in on a Monday morning and realize the kid was in the emergency room, and they couldn't figure out why. And in almost every case, short of weird broken arm or whatever,
Right, sure.
It was because of a dental-related issue. So the pediatricians took it upon themselves to make sure that every kid in their care got sealants. And the amount of ER presentations just dropped, I mean, just unbelievably into our system. And so I would encourage folks to look at making sure that a sealant practice is actually in place. The other thing I was going to mention as it comes to, because I have a very rural area and we have challenges trying to find practitioners from rural areas, which a lot of people do, obviously. And you wouldn't think Florida being that rural, but 32 of our counties are rural, so we have significant issues that way. I passed a couple of bills that have addressed that. We provide our dentists with continuing education credits if they will volunteer in a rural community for their licensure renewal. You know, you work a certain number of hours in a community, we give you a certain number of continuing education credits that, you know, allows you to renew your license without, you know, additional costs and things like that. We also expanded last year our voluntary health services to provide all providers with sovereign immunity when they're working in a clinic environment. One of the things that in our state is becoming a challenge, and maybe you can address this, dealing with patients who are disabled, when you have severe disabilities, or even some that aren't as severe, be it Downs or other things, we're finding a significant challenge trying to find providers who will take care of those patients regardless of whether they're in Medicaid or not.
I'll take that part of it first. For those with disabilities, you're right, that is a challenge. And there is a program that's been instituted in many states. Dental Lifeline Network is what it's called now. And they're a group based in Colorado. But they go in and basically ask the state for like $50,000 for a coordinator for the program. And that person then is charged with recruiting a network of volunteer dentists to provide care to those severely disabled individuals who have real barriers to care and can't access it. There are specific skills that oftentimes come into play when treating a population like that a general practitioner may or may not have. Additionally, there is the issue of if there's surgery being done in the mouth or even an intense cleaning, whether or not that patient can stay still enough to let the procedure occur. And so if they cannot, then hospitalization and general anesthesia come into play, which obviously is a more expensive encounter, but ultimately if that's what's needed to get that person to a healthy state that we can then hopefully maintain, that's probably a wise investment. So it is a complex issue. I think two primary things. That Dental Lifeline Network is an important thing, but I think education for the provider community is also vitally important. The one thing I'd point out is when you're talking about some of the things you've done to bring folks to underserved areas, there are some real systems out there that work. One of the most innovative ones that I've seen is the state of Ohio. They put a $25 surcharge on their dental licensing fee to pool that money. And each year, they will basically incentivize a doctor to go into an underserved area to establish a practice, as much as, you know, building the bricks and mortar for them. And it has been a wildly successful program. And of course, then there are loan repayments and those sorts of things. But and the sealant, that just goes to reiterate what I was talking about, let's prevent the disease ahead of time, and the importance of collaboration with other health professionals. You know, if a pediatrician or a nurse practitioner looks in the mouth, if something is terribly awry, they may not know what it is, but they can probably see that there's a problem and say, you need to get to your dentist. So I'm sure my clock has run out, so I will walk away, and thank you very much.
Okay. We have with us this morning Mohini Venkatesh, who is the Vice President for Practice Improvement of the National Council for Behavioral Health. You're saying to yourself, what the heck is that? So the National Council for Behavioral Health is the national group that supports the community mental health centers in your states. And Mohini comes highly recommended to me as someone who knows both how to do clinical practice and knows a lot about the clinical work going on in states, as well as the public policy piece. So she's here. It's another one of these intersection pieces to answer your questions about Medicaid, behavioral health. What's the connection? How do we leverage Medicaid to provide better behavioral health services to the people that need them in our state? And she is on a bit of a time crunch. She agreed to come here, but she's got a call to take at noon. So I'm sure she'll go through her slides, and then we'll have a few minutes to ask questions of her, but she is going to have to move on because she has another obligation. Got our slides. And there's a clicker right there. Thank you very much.
Well, hello everyone. I'm sure you all want a stretch break, so I'm sorry we have to jump through straight to my presentation, but if you feel the need, feel free to stand up. It's not a distraction at all. Thank you very much for having me. You know, it's a really exciting opportunity actually to talk with all of you. A lot of the work that I do at my organization is about system redesign and how do we think through from a policy perspective, so thinking about financing, clinical issues, organizational change, how do we get folks who historically don't talk to each other to talk to each other to try to change the situation for a low-income population. So really excited to have this conversation with you today. I will go through at least some of my slides. I don't think in the interest of time I won't go through all of them, and I'll make sure to save plenty of time for Q&A. So as Deborah said, I come from the National Council for Behavioral Health. We represent over 2,000 community-based mental health and addiction provider organizations around the country, serving over 8 million adults and children that are struggling with behavioral health problems. So of anyone, you all are certainly acutely aware of the incredible amount of change that we are in the midst of. And a lot of times I think it's a struggle to sort of keep track of everything and figure out what precisely is helpful, and figuring out the intersection between policy and politics, what's really doable, both in short and long-term goals. So very briefly, when we think about so what were the changes that occurred with the Affordable Care Act, I'm sure this kind of analysis is not all that unfamiliar to you, but we know that the ACA certainly will facilitate coverage, health insurance coverage for many more people than pre the Affordable Care Act, but there's still going to be plenty of people that remain uninsured. When you look specifically at the goal of the Medicaid expansion, you can see that there is a drastic growth in how many people are covered through state Medicaid programs. So this puts a huge burden, responsibility, opportunity, however you want to look at it, on state Medicaid offices to really navigate coverage of all of these folks. So getting them enrolled rapidly, and thinking about a benefit package that really tries to help to meet their needs, control costs, and really think about population-based care, really reducing the overall expenditures that we're all spending right now. We know also that with the Medicaid expansion, the fundamental difference it created for people with mental health and addiction disorders is that historically, Medicaid did not cover people that have addiction as their primary diagnosis. So what that meant then were that those folks remained uninsured. Moving forward with the Medicaid expansion now, it is not based on diagnosis. So it's simply based on your income level. So all of a sudden, all of these people that are uninsured and had an addiction now can access Medicaid, and that the states are getting a higher federal match for their coverage. So we know that on the mental health side, that also we'll see more people with mental illness getting coverage through Medicaid, but really the drastic growth area is for people with addiction. And so there's the coverage angle of this, but then there's also the service capacity and the system capacity angle, right? Do we have the systems in place to actually provide services for these folks to make sure they're not ending up in hospitals, in jails, and elsewhere? So this is a slide that's just showing what states are doing the Medicaid expansion and not. My guess is there's a mix in this room of states that are doing the expansion and some that are not. And what we know here is that there are incredible opportunities, I think, with a lot of the changes that are happening in systems. We know more and more the impact of mental illness and addiction on both the healthcare system, but also other social supports. When you think about the public education system, jails and prisons, and other kinds of social supports, we're really feeling the burden of there not being a proper prevention and treatment system available for these conditions. Of course, the big things that make the news, the shootings and other violent incidents, is that commonly the perpetrators are sometimes have mental health problems, but more often than not, there are also victims of this violence as well. And really, these are viewed as failures of our system and an opportunity for us to try to fill in some treatment gaps. We also face a whole bunch of struggles right now. The system is incredibly siloed. The Medicaid coverage expansion certainly helps with that because it facilitates coordination of care, that now people with addiction, they can be on Medicaid rolls and can get access to health care quicker. But there's still some challenge areas that we face. Access to care is a huge problem, in particular rural states. There's huge workforce shortages, not just in mental health and addictions. Primary care has huge workforce shortages, and that's a big concern for people with behavioral health conditions because many of them access their mental health treatment in primary care settings. And so we're very concerned about that as well, that there are some really big shortage areas right now. So I'll just very quickly mention this slide. It's simply, the orange section is simply highlighting for states that, excuse me, that do not do the Medicaid expansion, that the orange are the folks that still will not have any health insurance coverage. And this is another opportunity area and a population that we need to be very carefully focused on moving forward, because they're the folks that are going to still be overutilizing very expensive services at the state level. So once again, the ERs and the jails and the prisons. So, there's obviously a lot of sort of change occurring because of the Affordable Care Act, but states, even prior to the ACA, you all know this very well, have been doing a lot of innovative things around trying to redesign systems. And what I'm going to focus on right now is this concept of accountable care organizations. It's a lot of times when people think about innovation in Medicaid, they only focus on the insurance expansion and the service benefits, but actually states are exploring the possibility of redesigning the delivery of services for Medicaid beneficiaries. And there's incredible opportunity to help patients make their care more coordinated, but also for states and for community systems to rethink how they're delivering services. How many of you are familiar with this idea of an accountable care organization? Okay, so about half the room. So the idea with this is the new hot topic in healthcare. And the idea right now is, so I'll take myself as an example. I'm getting over a cold right now, and so I go see my primary care doc, and they're saying that, well, you need to go get a scan of your chest because you have some congestion and it's been going on too long. Well, they can't really give me a referral to someplace where I can go get a scan. But I call my insurance provider, I find out where it can get covered, I go and I get that scan done, and then I go back to my primary care doc and they still don't have the results of my scan. And that's really frustrating. And so I'm supposed to remember what the people who did the scan for me, what they said was wrong with my lungs, and then report that to my primary care doc. And you can imagine there's all sorts of challenges with that. I'm sure that you all can think of examples in your own life where things are just highly uncoordinated. The idea with an accountable care organization is that all sorts of providers, and I don't want you to limit your thinking to just healthcare, it really can be all sorts of community support, all working together. They're communicating to each other. There's an infrastructure underlying the services so that the services that are being provided to the patients is really well coordinated, most efficient, and the providers are, this whole ACO structure is receiving a lump sum payment to take care of the patients that they're serving. So it's completely redesigning how healthcare providers are paid for the services that they're offering. And it totally changes the way the patient then is able to access care. So what's really interesting is that the ACA authorized a demo program in Medicare, so Medicare is the program for older adults, to launch accountable care organizations around the country. So that program is going on, and in the meanwhile, states have decided, well, gosh, this is a really interesting idea. Let's try to do this in the Medicaid population as well. So they've sought waivers from CMS, and there are 4 states now that are doing things that are like accountable care organization structures. They call them different things. And all of them, except Colorado's, specifically is inclusive of behavioral health. If I had more time, I would share with you sort of the data about when you're thinking about the people that are high cost for the system, you have to focus on people with mental health and addictions because they're very simply high utilizers. You guys know this. So right now, the Medicaid ACOs are serving about 1 million beneficiaries. So I'm going to focus very briefly on one example of these state ACOs that are focused on Medicaid populations. Is there anyone from Oregon here? Oh, nobody from Oregon. Okay, so they decided a couple years ago they wanted to go for it. They established these entities called Medicaid Coordinated Care Organizations that are focused on low-income populations. And this was just a sort of presentation of why they needed to go in this direction of thinking about a coordinated, integrated treatment system. And really what the claim was that when you think about traditional healthcare, it's only addressing that simple 10%, the medical care angle, and yet we know that there's all these other factors that influences one's health. And so these coordinated care organizations are an attempt to try to address all of these things. Big picture, ACOs, particularly the ones that are for the Medicaid population, they're focused on these 3 core elements, a lot of prevention and wellness, keeping the people that currently have a chronic illness out of hospitals, and then also trying to reduce the amount of readmissions, because these are all of the sort of very expensive things that go on in healthcare right now. The idea also is to pay for value, not volume, so moving more and more away from a fee-for-service of, well, I had a patient come in 20 times over the past year, so I should get paid a sort of consistent rate for those 20 times. Alternatively, you're paid a lump sum amount as a provider, and it's your job to make sure that that person doesn't use a lot of healthcare, because you're going to lose money if they do. So you're going to want to do a lot of wellness and prevention programs to keep their costs as low as possible. So I'm actually going to skip this in the interest of time and hit the pause button and see if you guys have any questions or comments. Please.
The healthcare, with the Wellstone Diminishing Parity Act,
Yeah.
I feel like we've got some indication that it's just not really happening yet. That's the law about paying the same amount for mental health services as other kind of medical conditions. Is that still, a big factor in play?
Yeah, that's a great question. So taking a step back in 2008, so before the Affordable Care Act, law was passed and signed into law that required that if a health plan provides both physical health and mental health services, that they have to do so at equity with each other. It did not require plans to cover mental health if they didn't already. And through the regulatory process over the last few years, there's also been other caveats that have been inserted. So right now, parity does not apply to Medicaid managed care, for example. So that's a huge problem. Regardless, right now, parity is being enforced for the health insurance exchanges in your states. All of the plans have to be in compliance with the parity law. It is really hard to assess compliance. It's very, very technical. And so we are getting some reports of just concerns around non-compliance, and suits are being filed. But we're not going to see the great benefit of this for another 10 years still.
I'll ask another question if I can. What about the idea of reimbursement for telehealth and telepsychiatry and teletherapy?
It's a great question.
Big savings. Do you see that as is Medicaid paying for that, or is there still a battle to be fought about whether that will be reimbursed?
There is still a battle to be fought about that. This is a regulatory issue. So the VA and Medicare now allow telehealth services across state lines, but Medicaid and private insurance still do not. So what that means then is that it drastically limits the availability of telehealth within Medicaid. Despite that, we've seen a lot of sort of organizational innovation around this. We're seeing states that are supporting grants for telehealth. There's also a sort of incentive payment program through CMS to encourage providers to do all sorts of e-technology work. So we are seeing the growth of this. The other challenge as well is what are the types of providers who can do telehealth? It's also a grave challenge. When you have particularly a prescriber shortage in rural states, telehealth becomes very, very important. And so I've heard of examples where, there'll be a hospital system that crosses a few states. They really want to provide telehealth in one of their states in which they have a major shortage to help with prescribing issues, but you're not able to cross state lines right now. So it's posing a big challenge. And this is both a state and federal regulatory issue. Yeah. Yes, please.
This question is set from about 6 months ago when I listened to a professor from, actually doctor, psychologist from Johns Hopkins talk about the fact that if you looked at the 18 last mass murderers in the United States, if you looked at the medications that they had been taking before, during, should have been taking, or didn't take at all, there were similarities in almost every one of the 18 cases, which brought about the question, if the pharmaceutical companies know that they have something that's affecting the mental stability of some of the patients that they're giving these drugs to, how do we as states, knowing that information, how do we begin to try to impact the culture that allows us to say, look, or encourages us to say to those providers, you got to be a little bit more careful about what you're doing. How do we do that? How do we change the culture? What kind of legislation should we look to try to do that?
Yeah, so while I agree with you that there is a lot of commonality regarding the prescriptions these people were on, the underlying problem here is a question of, are they being prescribed the right meds, and are they getting the wraparound treatment? So, as soon as you think that medication is the only answer, there's a problem there. And so when you look at a lot of the people that have been perpetrators of these recent incidents, what you find out is that, yes, they were on antipsychotic or an antidepressant medication or something to control ADHD, for example. What you also find out is they're not in treatment. That they may have tried to access treatment through their school, through a community system, but they were not consistently in care. And that's actually fundamentally what the problem is, because if they're seeing a licensed provider, they'll be able to track things a little bit more and actually be able to provide wraparound treatments. A lot of the folks that are perpetrators, they've been isolated from society, they're cutting themselves off from their family, they don't have jobs, they're not in school, so they're losing their social connections. And a treatment provider can actually call those things out and provide them with case management and support so that they're in comfortable settings getting those services.
If I may, a follow-up question.
Sure.
Kind of associated with what I'm saying. tremendous amount of money in prosecuting a number of, say, marijuana types of cases.
Yeah.
Yet many of us know that the marijuana and alcohol, very similar in behavioral uses. Lots of money has been spent over the years in prosecuting and trying to enforce marijuana laws.
Right.
Not enough money has been spent in trying to advocate for the behavioral uses. Is there some kind of effort to trying to approach Congress or somebody else to try to move money away from the enforcement side and put that money in the treatment side?
Well, so until it becomes legal, this Congress can't really, I mean, the federal government has made it clear through the regulations that, you know, this is an illegal substance, and while they're not going to stop states from legalizing it, so that because it's illegal at the federal level, it limits then congressionally what kinds of work that you can do around transitioning that money over to treatment. The one element, though, where that is not the case is around treatment courts. So I'm sure you've heard of mental health courts and drug courts and veterans courts. The drug courts are more and more now taking on marijuana. Historically, they did not. They focused more on other illicit drugs and alcohol. So we are seeing more and more drug courts that are sort of focusing more on marijuana. There's a lot of public education that needs to be done on that, however, because the treatment modalities and also just recovery issues around marijuana use are very different than other drugs. And so those treatment courts need some education around that to be able to thoughtfully do their work.
Thank you.
Yes. I think there's another hand, yeah?
Oh, I just had a question back to the ACOs. So you've started 8 of them in the last year, and one of the components must be mental health. I wondered if that was a federal requirement for an ACO, or if states can do that on their own.
That's not a federal requirement, but the reason why states are doing it is when you look back at these goals. That the biggest complaints we hear 10 years ago when we would talk to hospitals or to jails and prisons and we would talk about this population, they really were not willing to have the conversation. And I don't blame them. I mean, they have tons of other things they're focusing on, but now they want to have the conversation with the specialty behavioral health community because they're looking at their data and they're seeing who are the people that they're serving the most. And it's this population, and it's a population that's the most troublesome. You hear the most articles about, and just last week I read an article about someone with schizophrenia that was in a prison in, it was a jail in Florida that was killed in the jail, and it's become this huge drama in that state now, and they're having conversations about reform. So it's really the motivation to reduce costs and to control those hospital readmissions. When you're thinking about what are the target populations, your first thought is chronic disease, and then when you break that down even more, it's cardiovascular disease and it's people with mental illness and addictions.
Well, that's why I brought it up, just because we felt it was important in our state going forward with care coordination.
Correct.
To include that component on mental health, and people that know that that's so important, that I think that is an essential component of it.
That's a great point. Yeah, I mean, and the co-occurrence as well of when you have a chronic physical health issue, diabetes, cardiovascular disease, the rates of depression are so incredibly high, and that drastically impacts your recovery from the physical health issue. And so these things have to be addressed.
One other issue about the ACO, though, at least in our state, is they do not verify risk like an HMO does.
They don't what, I'm sorry?
Bear full financial risk.
Right. So there's, if I had more time, I'd share another slide with you about just sort of the risk sharing models that are currently at play with accountable care organizations. The idea is over time, these ACOs are getting this lump sum, and that's what you got for this patient, and you do the best you can to manage care for them, and if you save money, you get to enjoy that bonus to do other wraparound services. If that person overutilizes care, then you're in the red for that person for that month. to make that transition from where we currently are takes a multi-stepped approach, and it requires a whole bunch of stakeholders to agree to that. And so what we're seeing right now, given that these are so new, they're at most a couple years old, we're not quite there yet. There's also accountable care organizations and private insurance are paid for through health plans. The health plans have to agree to it as well, and they're scared of losing their control and allowing a provider group to make those kinds of treatment decisions. So it's going to take us some time to get there. Yes?
I'm just curious. Our previous speaker, we discussed about inmates that were on Social Security or SSDI, and but when they go to jail and they get incarcerated,
Correct.
for the reason they lose their coverage.
Correct.
Do you see that as a chronic problem?
Oh, yes. So Medicaid suspension versus termination is a top priority issue for this population when you think about Medicaid coverage. Most states terminate coverage for Medicaid as soon as somebody goes into the justice system, and there's a lot of misunderstandings. They think that it's a federal government requirement, and they're just following that, and that's actually not true. You can suspend benefits. I mean, people cannot be on the Medicaid rolls. States can't be getting reimbursement from the federal government for these people while they're in the jails and prisons, but you can do something called Medicaid suspension so that they're staying on the Medicaid rolls officially, but it's almost like you're just hitting the pause button. It makes it much easier when they come out to turn their Medicaid benefits back on. But there's very few states that do that right now. This has always been a problem, but particularly now with the Medicaid expansion, it's an even bigger issue, and it's something that for sure state legislators and regulators can address. Thank you. I will